excited to have our two speakers for today and to have all of you attending. So I'm going to turn it over to Dr. Shaheem de Vries now to give his presentation.
Hi, thanks, Rory. Just to say hi, and so people can see who is making these ridiculous claims. So that's me, and thanks very much for inviting me. I look forward to sharing some time with you guys. Always great to escape, even if only virtually, from COVID. Can you just confirm that you can see that, Rory?
Yes, we can see it.
Great. So thanks very much to Abram for the invitation. So when I received the invitation, I was asked to choose one of these, so I couldn't choose, and so I'm going to try and do everything. But I will try and focus on the things that I found particularly useful, or shall we say, humbling during this time of COVID. In South Africa, it's starting to get real. We've been in lockdown for nearly more than 60 days, I think, and so our numbers are starting to climb. There's concern as we shift out of level 4 into level 3 that will climb even faster. So at the moment we're sitting at approximately in the Western Cape about 16,000 infections. We are what we call the epicenter of the country, although I'm not so sure that is entirely accurate. But we do have the most infections. We also have to date about nearly 400 deaths, about 370 deaths, and a considerable number of staff have been infected across the health department. So it's starting to climb. Our hospitals are reporting very high occupancy levels, and we're running into problems around bed resources. So that just as a way of trying to set the scene. So I'll try and get through our experience. And to do that, it's been very difficult to try and figure out how you tackle this. I thought I would punt some work done by a few colleagues, really great work. And so I'm going to use the pre-hospital emergency care checklist to structure my presentation and sort of just dive deep into some of these things as they come along. If you are in EMS, you are working with an EMS, it's very worthwhile going through the checklist. I found it particularly valuable, just trying to benchmark what we're doing. I must confess, I think it's specific for our context. Many of the really great people working on it, but a large proportion of them come from our system, and so probably reflects that bias, but certainly worth the read. So the first part, just to get it through, is family and companion response and dispatch. These are the first two sections they color-coded within the checklist. So the first, the first thing we did was establish in addition to panic, was establish a major incident command center. We did that fairly rapidly. Within a few days, we had a additional major incident contact center with staff, call center, software and applications set up in that time. That's because we had an existing vendor able to bring our contact centers live, and so we just sort of pulled on them during that time. The National Department of Health created a website and WhatsApp group and was particularly innovative and progressive in how they did that. Both formats were essentially one way, as you can imagine. Two-way communication just would not be manageable. But it was a very useful way of disseminating information. Our center was staffed by students and our college staff, and they essentially ran through a workflow under the dispatch around the Spectrum application, which was changed based on the disease case definition. And this allowed us to screen and refer patients telephonically. as well as track them and the workload. It had the ability to do hotspots as well, so you could see where these queries were coming from. But this was becoming, in the early parts and even now, becoming a contentious issue since then large amount of stigma to the disease and fear that's out there. Also within our dispatch, we started it started affecting the routine work, so we needed to train up our emergency contact center staff around case definition and pre-arrival instructions. The interesting thing, I think, is EFAR. Often we have a very long history of emergency first, or what I guess is now known as CFAR, Community First Aid Response. And I guess when you have a pandemic, that gives you the ability to scale and respond to surge. But due to the lockdown and the lockdown restrictions of movement, even right now, EFAR and EFAR involvement is not a resource we can tap into. And that was just interesting in terms of previous planning and thinking and how COVID has changed that. So this is probably the part I will spend the most on. It's the part that caused me the most grief. It is around our emergency care providers. We're pretty fairly robust service, really good systems and processes in place. But even having said that, this has caused me and my team considerable difficulties over the last 2 months, and in particular around scene control and care. I've used the words as they appear in the checklist just to re-emphasize the value of the checklist and structuring your thinking. But it essentially deals with adequate PPE and training, a clear policy outlining each provider's role, a screening tool based on the case definition and all IPC guidelines in place. And so there's many other things in the guidelines, but these are the ones I've lifted out to try and chat to. Yeah, and this is the problem, I think. Adequate personal protective equipment. When the first reports started coming through, certainly at a mass media level, around about January, Dr. Wayne Smith, who heads up our emergency medicine unit, we responded. We got training out to all our staff around, in particular, donning and doffing of PPE. And the thinking at that stage was A40 suits in terms of what we knew about the virus at the time. And so we went out with mass rollouts, and this is a picture of one of those sessions held in early February, late January. The table at the bottom is an extract of one of the guidelines the department put out as soon as we went into lockdown. And you'll see there under type of PPE or procedure, it speaks about surgical masks, A40 suit, apron not practical when worn outside, especially if windy, and non-sterile gloves, etc. And that portion, just that one sentence, has resulted in substantial mayhem and chaos. Maybe I'm exaggerating, but certainly substantial difficulties encountered within the practice domain of the service. And I've listed it as being perhaps too responsive. Even later on, the guidelines that came out of the national department and from the WHO did not mention suits anywhere. But because we trained these early in February, and the media was filled with fear and about people dying, and we saw pictures of health systems collapsing in Europe and across the world, those images were very difficult to shake for staff. So producing a clear policy, which we then did, the moment that the table came out, it was unsustainable. We were going to run out of suits very, very quickly. It was amidst a PPE shortage. And so it was extremely uncertain that we were even going to get enough suits to begin with. We then issued new policy, which emphasizes a footy suit, in fact, doesn't mention the suit anywhere, and instead speaks about the apron and N95 respirator and the surgical mask. And these guidelines went out from the provincial department. And then a few days later, the provincial guidelines came out, and they'd essentially cut and paste our old guidelines. So after we put out these guidelines, the national department came back and mentioned A40 suits again. And this made our staff relationships incredibly difficult. My 2IC provincial chief and I then spent the next 4 or 5 days going across the city, speaking to the shift. These are pictures of those at Pinelands and Mitchells Plain, two of our bigger bases. Trying to allay fears and deal with the panic that had followed this idea that we were not able to give them A40 suits and instead of giving them plastic aprons. And this was difficult for several reasons. Number one, no one was really interested in what we had to say. And number two, how do you do this when we are advocating for social distance? Masks were not really a thing at that stage. It was very early on in our response, so none of these pictures have face masks on them, but certainly social distancing was, and it was very difficult to conduct what are very heated and emotional laden conversations and still get staff to keep physical distance. This had a knock-on consequence of the failure about us to reach an understanding on this resulted in a work stoppage. And so the first screen grab is from a picture from Kalicha Base. They decided to down the tools, demanding that we issue them with A40 suits. And these are all serial captures from people's Facebook profile where we came under severe criticism for seemingly uncaring attitude towards the staff. It was very difficult to cut through that fear and anger by appealing to the disease and the way the disease spreads, this did not really resonate with staff in any way. No matter how we emphasized the fact that there's droplet spread and, you need to watch your personal hygiene and touching your hands and, touching your nose and mouth with your hands. That didn't, all they saw was that they see these scenes of A40 suits in the media in other parts of the world. They see this on policemen. They see this on health workers in our system, but they don't see it within their service. And so this caused, for 3 days, we had downing of tools, and that's still currently trying to be resolved. I'll come back to some of the initiatives a little later on in the presentation. So the next thing in the checklist is patient transport, and in particular it mentions the provision of safe ambulances. It also speaks about private sector partnerships, and we'll talk a little bit about that. And then the orange section, or I don't know what color that is, somewhere orangey pink, transfer care, and we'll chat a little bit about that. So around the availability of safe ambulances, the teams were quite proactive. We covered our seats in plastic. The picture at the bottom shows the floor of an ambulance covered in plastic sheeting. This was in the early stages where we were responding with dedicated COVID, or shall we say infectious disease ambulances. And so you'll see there, they took the time to tape down all the surfaces and outlets and points so that it could be easily cleaned. You also see in the picture on your there's a screen. They essentially then sealed off the compartment between the driver and the passenger, and thereby also increase the safety through barrier mechanisms. The checklist speaks about transport of family members. This was done through our partners in the Department of Transport and Public Works, which is essentially a department that looks after the public transport system. And they went on a mass campaign to move initially health. Transport was shut down due to lockdown, and so health workers couldn't get to work. And eventually, after several weeks of struggle, established a what they call the red dot and a blue dot, which transports health workers to and from their homes, while the public transport system was unpredictable. The interesting thing here is this does not happen in a vacuum. So these were the pictures taken when the minister made the public announcement, and you can imagine my dismay to see taxi drivers in A40 suits and face masks when I'm battling with my staff to get them into aprons. It also speaks to I guess the craziness of it all. The gentleman right in the foreground of the picture is wearing a full A40 suit and mask and flip-flops. And I guess it's this ability of not understanding either the disease or the protection or the context that makes communication amidst fear and anger exceptionally difficult. One of the things that we did spend a lot of time on is education and engagement of staff engagement. So under the checklist, there's a section called transfer care, and our approach to that, and speaks to IPC guidelines, it speaks to educating staff, it speaks to medical guidelines and so forth, and the amendments that needed to the practice. So we'd conducted some research through colleagues of ours from Colorado around HEAT, and HEAT was essentially high efficiency emergency care training. It essentially draws for its principles on Helping Babies Breathe program. Those of you who are familiar with the Helping Babies Breathe program, in a nutshell, it approaches the refreshing of clinical skills, so actual skills, not necessarily theoretical knowledge, in contexts that are practice contexts, so either at the bedside or in our case, in an ambulance. And it does this in tiny aliquots of no longer than 15 to 20 minutes. The training is peer-driven and has a very low ratio. So in other words, there's usually one facilitator to 2 or 3 staff members. And what it does, it enables, the combination of this enables a very rapid rollout. So we were able to train, and that was the problem with COVID, is the new information was coming out all the time, almost daily. And case definitions were changing on a weekly, 2 weekly basis. And so we needed to find a way to train and retrain that fits in with the system. And so training happened 15 to 20 minutes before the start of shift. They were peer-driven and they were tiny little aliquots. I can later on. I'll show you closer to the time some of the material. And again, you'll see this time face masks started to come in, and you couldn't have more than 10 people in a gathering. But they essentially had 3 modules: looked at IPC, clinical care, and decontamination. So these are clinical care guidelines. Here we had to train staff on using spacers instead of nebulization because of the risk of aerosolization. And so they received training material as well as the equipment during the session. It was very important that we didn't just train them in the theory and not provide them with the necessary equipment. So sometimes training was delayed until we solved the supply chain issues in order to get them there. So it was a very carefully orchestrated training engagement, and the team really worked really hard at that. So I'm going to just show you a video. This is, I won't play the full video, but this is the video that the team made around donning and doffing of N95 masks. Yeah.
Good day, I'm Phil Baker. I'm going to demonstrate the donning and doffing of the N95 face mask. Firstly, I'm going to sanitize our hands. Then we're going to take the appropriate size gloves. We're going to sanitize our gloves. Now we're going to select the N95 mask. When we pick up the mask, just make sure that we touch the outer rim of the mask. Right? Then we flip the mask over. And make sure that the strap is hanging at the bottom. Now we're going to grab hold of the bottom strap. We're going to apply the mask. And then take the other strap. Again.
So in order to supplement the material, the format for the facilitation is also what was developed as part of the research program. And so these training sessions were quite carefully planned in that they had to follow a specific recipe. And having that template up front meant that the teams were able to rapidly produce content within that framework. And I just want to share that with you quickly. Right. So the first part so this is an example of a facilitator's guide. And it uses the icons to show what happens. So this one is around donning and doffing. So there's an introduction, speaks about the objectives. There's sort of critical points, so uses these iconography to sort of say, you need to emphasize this. When it gets to a task, there's a little task icon, and this was around donning and doffing. So they'd speak about how do you look after a mask, how does the mask get stored. Then they ask the staff to place the masks, and this is in a very small confined space. So everyone has dedicated time. We make absolutely sure that the skill is understood, and then it wraps up somebody. So that was under donning and doffing, and then with 3 modules. So this one is under the emergency care guidelines. So it speaks about how do you assess a patient. Again, you can see there's a discussion icon there's a talk icon, then there's a skill set. And this one was around an MDI and spacer demonstration. And then there's a summary. And these were the supportive materials that went with that, from a mild, moderate to severe, just showing the algorithm. Speaks about some of the previous stuff already covered, donning and doffing, what an aerosol generating procedure is, and so forth. And then under module 3, which was around decontamination, you'll see again the same format, same recipe, iconography, keeping it consistent, and then goes through up until the summary. And then there's some information that gets given out to staff. This one in particular was around donning and doffing at home. So there was a lot of fear around how do I protect my family, and so you'll see later on. So this is about, leaving your clothes. What do you do when you're driving? What do you do when you get home? And this was quite useful because staff were concerned that they were going to take the disease home with them. So this is just an extract of the circulars and the guidelines that they sent out. In the checklist, this falls under service delivery. So the turquoise section. Under service delivery is comprehensive IPC infection prevention control. Again, these are just graphs and pictures of the content that was produced. And most of our efforts were around engineering controls. Most of my time and the manager's time was spent around PPE, which is the least effective, something worth remembering. Part of the heat training was around decontamination. These are pictures from the teams that they set up their own decontamination sites, recommissioned abandoned areas of the station. So this is an old wash bay that they cleared out. This is a storage container that they turned into a decontamination area. The staff would don and doff. And then this is just examples of how they demarcated the spaces. I mean, some of these pictures come from the training material itself, and there's a video that goes with that.
Dear colleagues, once again, on behalf of the college and Emergency Medical Services, we would like to thank you for your participation in this training program. We know this is a very stressful and anxious time. Thanks from all of us at the training department and EMS management for participating in these training programs and ensuring that you are constantly updated and guided by best practice. We would like to ensure that you stay safe during this pandemic and take care of each other.
After returning from an infectious call, park the ambulance in the center of the red zone to allow free movement around the ambulance. When you get out of your ambulance into the hot zone, please don appropriate PPE, which includes your face mask, your apron, and your gloves. Use eye protection when you're going to commence cleaning. Also open your sliding door along with your back doors.
So I think most of our in the last efforts were around trying to train and get the message out. The type of training and things were really around the basics, things like wearing a mask and sanitizing and using hand sanitizer. The challenge that these presented is it is fine to have the knowledge. It is if you didn't have the hand sanitizer, if you didn't have the spacer devices, the training was ineffective, and so it required a concerted effort to align these things in order to be able to achieve it. The checklist just finishes off with administration. It goes to logistics and supply chain. I think this is my last few minutes. As I said, the 99 circles. This is a picture of the supply chain, not EMS. This is the broader department of health. That is our COO, that is our CFO. This was at a time when they were all supposed to be wearing masks and social distancing. Both of them came under fire from the management team for the flagrant ignoring of the guidelines. But I use this picture because there was a huge amount of effort that had gone into making sure that PPEs, and this was around PPEs, we were that stage not sure that we were going to have enough masks for the whole department, never mind for EMS. And even right now that is still an ongoing, and I imagine for many of you it's still an ongoing battle, making sure that we do not run out of PPE stock. The other really strong aspect was around the people management practices, and we already spoke to some of the OHS material that the department produced at the time. But this was also part of a risk assessment. So these are screening sites that we had to establish at the start and end of shift, where the occupational health and safety coordinators would screen every staff member. This is since then we've developed a mobile application that is self-administered and then forwards us the name of the person who tests, who answers positive for any one of those questions. But it's just an example of what was required, and then from the department in terms of your exposure and whether you go into isolation or quarantine and when you return to work and so forth. A lot of work and effort gone into that, and also a lot of discussion from the staff around that. The last section is around data management, and that's a topic on its own. Province has really done really well on that, the department. Security is interesting in the sense that red zones, staff attacks are still a issue. During lockdowns, we had 10 incidents of staff attacks happening while staff responding to the community, and this was in a time when alcohol wasn't freely available. You can buy it at the shop. You still can't do that. And so that's been an interesting thing, is that the world hasn't changed, although everything's changed. Some of it hasn't really changed, and so that's still a consideration for us. And the last item, which is not necessarily I want to speak a lot on, but I think is something that is real, and that's around not just volunteers but social solidarity. This is just pictures from the staff. The item here is staff vandalizing their ambulances. It was a quiet afternoon, and so they decided that they wanted to write messages to the community about staying at home. This was really, and that's a product. It was so well received that we got a sponsor that sponsored the provision of stickers, and essentially used the exact font to make stickers about staying at home in the various languages. By washing your hands and so forth. An example of how these responses and organizational responses come from different places. The staff enjoyed those of certainly went from the reports I got, enjoyed defacing their ambulances, and so you still find quite a few ambulances driving around with these stickers. Then the other aspect is while staff were downing tools, some of our facilities in support put out messages of support to the staff and raised it around COVID. And this is from Mitchell's Plain Hospital. The doctors put that on their Facebook page. Something which we won't go into here, but which is a feature in the Cape Town and other areas of Southern Africa, is this community action networks, or CANs. One of our colleagues that works in EMS is quite involved with this, and so and that's part of something that we don't often in EMS in EM speak about, but it's certainly a strong force, and that is citizen action. We have seen that pop up many times, and some of our staff are active members of these communities. So maybe just the last few take-home points. I think the issue around the checklist, it's really a useful framework to help shape your thinking if you get a chance to go through it. But having said that, EMS systems are organic and emergent. They develop on their own trajectories. Our path is not your path, and your path not ours. I think you should draw on confidence from that system. Each EMS is decidingly individualistic, even though there are broad themes in that, and we shouldn't prescribe a path for any one EMS. Thirdly, knowledge, practice, and social aspects are entangled. Many of these things are not about staff not having knowledge. The downing of tools wasn't about knowledge. They knew precisely how the disease spread. They knew precisely how to protect themselves. They were just not prepared to accept that as legitimate. And we see that in their practice, the delaying of calls, the refusal to adhere. And we see that as ongoing conversations in what happens in society. There's lots of fear, lots of stigma out there, and our staff and medical staff are not immune to these conversations. And then lastly, I guess it's a terrible word. It's been used at unprecedented levels. We're using unprecedented, but I really do think that is the time to learn, explore, and evolve is rich at the moment. we've got nothing else to do and we don't really have a choice, so we might as well. So thank you very much. That's end of my presentation. It is an interesting thing. We made this very early on in our response to and essentially just messages from the families of staff that are on the front line. This then got picked up by the national department and popped up on a national website in support of the frontline staff.
On behalf of the children of all the healthcare workers, we would like to thank you guys for your bravery and your services towards the country.
A crisis doesn't make a person, it reveals what a person is made of.
To all the Metro EMS staff, thank you for the curiosity to find solutions during this unknown times. The collaboration by sharing ideas to make the best of what we have available, and the make it count attitude to take care of our community.
For their bravery, their services, and all of their sacrifices that they've made during this pandemic.
As the daughter of an EMS staff member, I just want to thank you for the selfless sacrifices that you've been making.
I just want to say thank you for all your guys' hard work, dedication, sacrifices and bravery, and for standing up and fighting against this COVID-19 battle that we are in right now.
I would just like to express my gratitude and my appreciation towards you for staying outside and keeping others safe.
Thank you to all Metro EMS staff for your unwavering commitment to keep us all safe.
Julle almal is baie spesiaal want julle is awesome. By still showing up at work despite your own fears and anxiety. I salute you for your commitment and dedication in this time of uncertainty.
Please stay safe. Please look after yourself and know while you are out there putting yourself at risk, going out day to day, we appreciate it. We stand by with you and we are praying for you.
To the public, I want to say, please stay at home. Help us to make our days' jobs easier. Please wash your hands and control the controllables, such as reaching out to your family, keeping your social distance, and once again, stay at home, please.
We would also like to wish you guys good luck with the rest of the 21 days of lockdown. And to the public, we would like to ask you to please stay at home and help keep our parents and their families safe.
To the public, please limit your social media exposure. Too much exposure to distressing news can increase your anxiety levels. Also remember to take care of yourself, especially if you are taking care of other people. And last but not least, please stay at home. Let's help make the work of the health workers easier and also help protect them and their families. Thank you.
So the first one is about the role of community health workers, which are, similar to the CFAR model, and how they should be leveraged during this pandemic, and then what it's specifically looking like in South Africa with CFARs not being allowed to sort of work and mobilize during the lockdown. Now that things are moving to level 3, what does that look like for CFARs? And how are you guys sort of thinking about that?
Thanks, sorry, great question. I know the question of, and certainly it's not a conversation I'm often privy to, the community health workers. But I know within the department there has been a lot around the potential that they present and the need to leverage that, particularly around testing and screening, much of that and tracing of contacts. We have not been, in my view, as successful at doing that, and only now starting to delve into that in the district health services. But I do think it's possible. In the post-COVID world, it's one of the things that I hope remain, which is we empower these community health workers and integrate them into the health system far more. For us as EFARs, it comes in connection with places like neighborhood watches. Many of the neighborhood watchers and community support NGOs were not allowed to move around, needed special permits, and even now it's still illegal for neighborhood watchers to move around. And so our fates are linked to that. There is a lobby nationally to get neighborhood watchers released as part of level 3, and then we start to prepare into getting our EFARs to be part of that wave. in particular around keeping people away from the EC by offering really basic advice and medical support. Yeah.
Awesome, thank you. And then the last one that we have is, as cases increase in South Africa, so the lockdown slowed everything, sort of gave time for the health system to prepare. But as cases are increasing, what are the biggest challenges that you all see, and what are the biggest sort of successes that you feel like you've been able to build around and sort of prepare for in the past couple of months?
Yeah, so I think, sure, that's an answer I probably have for you in 2 or 3 weeks' time, and then I probably know that it's wrong. I think the challenge we have is around moving people equitably across a platform like ours. South Africa has ingrained inequity, maybe not only South Africa, but I think it's particularly pronounced in South Africa, and particularly in Cape Town. We have a city that's been that grew up and designed around racial lines, and we have resources spread along those lines. And when you have something as ubiquitous as COVID, those inequities start to really leverage itself against the system. So our biggest challenge moving forward is how to spread the pain equally to everyone. It requires substantial coordination and systems. And so adding 1,200 intermediate care facility beds to a health platform demands of you to be really well connected and coordinated. And I think that we are not where we need to be. And I think that's what we're going to be really challenged, is getting people in the right bed at the right care across a system that is so inequitous.
Yeah, I think it's a challenge that's being felt around the world in all different countries. Well, thank you so much for taking the time and for sharing all of your insights and expertise with us. I know I learned a lot, and I think a lot of people will find this information really useful.